Okay, so a very good evening, friends. On behalf of the Indian Arthroplasty Association, this is our 39th webinar series. In this webinar, we're going to be having a lot of presentations on varied topics. Uh, on this day, we are only sticking to the problems around the knee, some innovations, some new tips and tricks that our Indian surgeons have devised. I hand you over to Dr. Kalai, who's going to be the moderator and the convener for this session. He will be introducing the faculty and then we'll proceed with the presentations. Thank you all. Dr. Kalai.
Yes, sir. So good evening, dear friends, seniors and juniors and all colleagues. So thanks for the opportunity. So today we planned just to discuss the surgical technique, tips and tricks, and to our latest implant designing by our own Indian colleagues in the past recent days. And we have been planned to do the webinar in a part A and part B session. Part A, we will be dealing with the knee, and part B will be dealing with the hip topics. And today we'll have some eminent speakers as well as the surgical tips and tricks which are useful. Straightly going into the topic, so I would request Dr. Sounder to present on the cup and saucer tibia influence and outcomes while doing the complex TKR. Over to you, Dr. Sounder.
Yes, sir. Is my screen visible, sir?
Visible.
Yeah. So good evening, everyone. I would like to share our share our experience on influence of MCL avulsion injury on the outcomes of primary total knee arthroplasty, with a special emphasis on cup and saucer morphology. So medial collateral ligament is an important coronal plane stabilizer in total knee arthroplasty. So the MCL injury is a significant complication and the incidence ranges from 0.5 to 3%. If you failure to address this intraoperatively leads to instability and need for earlier revision. So the MCL injury during TKA can be a mid-substance transaction. This could be due to the direct injury by the saw blade or from the femoral avulsion or from the tibial avulsion. This MCL avulsion injury could be due to the severe varus contracture, associated significant deformity or underlying osteoporosis and obesity. These are all the risk factors due to the patient-related factors. Coming to the surgeon-related factors, intraoperatively, while subluxating the tibia during the exposure or inserting the tibial trail in a tight flexion gap or hyperflexion of the knee, these are all the things which are described in the literature. So when we analyzed our series of MCL injury, and we could find that, we could recognize this important feature that is called a cup and saucer morphology. In this, the femur acts as a cup, and the proximal tibia with bone defect acts as a saucer, and this will lock the tibia while subluxating forward, and this could lead to avulsion injury from the medial tibial condyle. So this we have published in Journal of Arthroplasty in 2020. So this is a patient from 2011 to 2015. About 5,000 primary TKA were done in this study period. There were 46 intraoperative MCL avulsion injury. So the incidence is 0.8%. So the 3 patients were died and 2 were lost to follow-up, leaving 41 knees in the final cohort. So this is an example where there is a where we could find there is a MCL avulsion injury from the medial epicondyle, and this was fixed provisionally with the hook reduction clamp and was fixed with 2 screws with the washer construct, and final implants were placed with the cement. So this study group, that is 41 knees, were matched to 1:2 according to gender, age and BMI performed at the same period, with the control group of 82 knees. We could find that there are 4 important predictive factors by multivariate logistic regression. That is, there is a stiff knee, that is arc of motion less than 100, preoperative coronal deformity, which is severe varus deformity, and preoperative knee subluxation, and cup and saucer morphology. These are all the independent predictors of MCL injury. And we could find that this cup and saucer morphology in 28 knees when compared to 9 knees in the control group. This is an example where there is a severe varus deformity with subluxation, and the patient had a cup and saucer morphology in the lateral view, and this patient had intraoperative MCL injury which was treated with cup and washer screw construct, and this patient had an excellent outcome at the 5-year follow-up. When we reviewed the literature, the incidence of MCL injury ranges between 8% to 0.8%, and the most of the patient had a avulsion type of injury. I wanted to discuss 5 important points related to this topic. The first one is the severe varus knees associated with subluxation and a stiff knee. This is associated with the high incidence of MCL avulsion injury. When we compare to the other series, our series had a more magnitude of deformity and stiff knee. The third point is the cup and saucer morphology. This we have identified in 68% of the knees, and this locks the tibia and prevents the subluxation, and this is one of the predictive factor for or risk factor for MCL avulsion type of injury, and this is not described before. This is the recent meta-analysis which is published in 2022, and the treatment options for the MCL injury were primary repair, augmentation with the tendon graft, fixation with screw and washer construct, and if it is a severe form, then we can go for a thicker polyethylene insert or increasing the level of constraint. So when we look at the choice of the implant, we have used posterior stabilized knee in all the patients, and none has failed as a result of instability. This is in accordance with the Shahi et al. And Bode et al. But the Leopard et al. Showed that CR knees is in all the knees, and it is theoretically advantageous because the PCL acts as a secondary coronal stabilizer, thereby augmenting the stability. The increasing the level of constraint is an immediate and an attractive option, but we should be very careful because the Lee and Lotke et al. Published that among the 30 knees with semi-constrained implant, 4 had a failure. So the problem with the constraint wear, it leads to increased polyethylene wear, increased incidence of aseptic loosening due to more stress on cement bone implant surface, and increases the complexity, and it adds to the cost, and there is a less force bone for the future revision. So to conclude, intraoperative MCL bony type of avulsion injury is not a catastrophic complication compared to the transaction type of MCL injury. But the cup and saucer morphology with the background of severe varus deformity and a stiff knee, we should be vigilant about this MCL injury, and we should be very careful during intraoperatively. But this can be managed successfully with screw and washer construct, and no need to increase the prosthetic constraint. The clinical and radiological results were good to excellent in the midterm outcome without a postoperative instability or need for revision. So I thank the IAA for giving me this wonderful opportunity. Thank you, sir, everyone.
Thanks for the presentation. So we all deal with the severe varus, and we every day see the cup and saucer, but documentation and putting it in the document so that our juniors will be able to get the point. Whenever they see the cup and saucer, they will be aware that they have to take special care for the MCL, and they will also have an idea how to deal with such injuries. Better is to avoid such injuries. That is more important. So documentation is the key. Each and every finding we see intraoperatively, we must document, so it is useful to every one of us. So yes, thanks, Dr. Sounder. And hereby I will be request Dr. Yuvraj to share his screen.
Hello, Dr. Sounder.
Yes, sir.
I have a question. You said 46 cases of MCL injuries.
Yes, sir.
Did you have all of them in the avulsion from femoral component or substance injury as well as tibial?
No, sir. This is only group exclusive of only avulsion type of injury, that is exclusively from the femoral component. We have not included transaction type injury or tibial side avulsion type of injuries.
So all these cases were managed with screw fixation.
Screws and washer construct, yes, sir.
Washer construct. Okay. Thanks.
We have not increased the polyethylene size also, and we have not changed to TC3 type of implant also.
Was there any difference in the post-op protocol?
Yes, sir. We need to use. That's a good question, sir. Like we need to use a hinge brace for 6 weeks post-operatively. So even though we protect, we have used screws, we definitely need to protect the patient with hinge knee brace post-operatively.
Thank you.
Yes, thank you.
Dr. Sundar, one question.
Yes, sir.
How do you prevent this?
Yes, sir. That's what.
Any special? See, okay, you had injuries. Now the thing is, how do you prevent this from happening? People who are younger, as someone told, all of us do this.
Yes, sir.
So any tips, tricks?
That's what as I said earlier, first we need to predict the risk factors. So the 4 important predicting factors are whenever there is a severe varus deformity associated with subluxation and also stiff knee, that is less than 60 degrees of range of motion. That is the preoperative predictive factors for the like we should be very careful when we deal with intraoperatively.
So yeah.
Intraoperatively, when we go, we should not try to subluxate the tibia forward. So what we do is we cut a provisional cut, like a let's say like a 6 mm cut we can do, and we should not subluxate, try to subluxate. Then we should go for a femur, and after taking the posterior femur cut, then we need to put a Homan, and then we need to complete the posterior part of the tibial cut. So thereby we actually prevent the stress over the medial side.
So what I do is in such cases I take an osteotome, a curved osteotome, and take off the posterior lip of the tibia. I don't know what others do.
Yes,
so that the subluxation is very easy. Just knock off that posterior aspect of the tibia. You take an osteotome, and the subluxation immediately becomes easy. I haven't had.
The one caveat in that thing is like there will be a sclerosed posterior bone. When we take an osteotome and do that, there will be an uncontrolled cut. So there we will be taking more bone than what is required. So that is a good technique, sir. But if it is a sclerosed bone, then better I think what we feel is first to finish the posterior cut, so we'll have a room for doing all those completing the cut, and we can do that.
I think Dr. Sundar is correct in that first do the femur first, so that after you take that posterior cut, then you get some space that will be easier to do. It is important also osteoporosis. Osteoporotic bones, the avulsion is commoner compared to the normal bones, in addition to whatever factors you have told.
Exactly.
Thank you.
Thank you, Sundar. We can take some more questions in future, and Dr. Yuvraj is ready with the presentation. Dr. Yuvraj, please. We're able to see the
Dr.
screen.
Yuvraj is muted. We can see your screen.
Hello.
So we can see your screen. Can you speak up?
Not able to. Not able to hear.
Hello, can you hear me?
Yeah, now you yes.
Carry on, carry on.
Can please.
Can I go ahead?
Please do.
Please.
Please check if your slides are moving, Dr. Yuvraj.
Okay, Dr. Ravi, can you do the presentation? And
I have to stop sharing. Then only I can share.
Yeah, Yuvraj, please stop sharing, please.
Yeah, stop sharing now.
Good evening, everyone. Thank you, Ajit sir, Kalai, Rajkumar, and entire IAA organizing committee for allowing me to talk about our experience. It's not a research, it's an experience. It's called as free lift femur technique for avoiding the mid-flexion instability and also for the gap balancing. So you call it like that. So as all of us know, mid-flexion instability is a controversial subject and very poorly understood. Many of us blame on the implants, many of us blame on the joint line, many of us blame on the excessive medial release, which is uncontrolled sometimes, especially in Indian scenario where the deformities are more. So this involves the knee, 45 to 90 degree, and the potential reasons may be component design or anterior excessive release of the MCL or the joint line elevation, one of the things. So patient usually with mid-flexion instability present with repeated effusions, and they have subjective instability, quadriceps weakness, and have periretinacular pain. And also the statistical analysis of the meta-analysis shows that whatever patient outcomes, the revision done for the especially the flexion instability have lower scores, functional scores compared to the other etiologies. So we should be very careful in doing this. In the present era of robotics and all, there is a huge role of assessing quantitatively and qualitatively what are the or gaps like in all the range. But still, the conventional TKR, what all are doing, has a beautiful methodology and also time-tested technology. Instruments can be utilized for our proper balancing. So what we do is we do the extension gaps assessment after the proximal tibial cut and the distal femoral cut, and whatever is required, as Saundar was discussing, to prevent the medial collateral ligament before subluxation, that's true. But if you release the posterior capsule and use a very thin osteotome and remove the posterior flare of the tibial condyle and release the posterior capsule in up to mid-coronal plane, so definitely it can be subluxated. So if you do that and do the both cuts, then assistant will lift the femur on the head end side and check the flexion gap. Usually the flexion gap can be quantitatively assessed when we do the posterior condylar cut. So if the flexion gap is already loose, intrinsically some patients are very loose who have a fixed flexion deformity or whose bony anatomy is like that. So they will have very loose. Then we measure with a scale. If the flexion gap is already more than 4 mm, we call them loose. If there is minimal opening, less than 1 mm opening, we call them tight. So after removal of posterior osteopoids, everything removed, then we check the one more time and trialing, and then we understand what to do. So for example, if there is loose
Ravi seems to be having some network issues.